Hello, everyone. Before we get started with the webinar and the introductions, let me say a few words. We are all deeply saddened to announce the passing of Dr. Jeremy Wollstone yesterday. He was the Raymond and Anna Lublin Professor of Geriatric Medicine at Johns Hopkins University and a pioneering leader in the science of aging and frailty. Dr. Wollstone made transformative contributions to geriatric medicine, including the co-development of the frailty phenotype, now a foundational tool in both research and clinical care, and an area where we certainly have a deep interest. His groundbreaking work on the biological underpinnings of frailty, including the role of mitochondrial dysfunction, inflammation, and the angiotensin system, have defined the targets for interventions to prevent decline and preserve function in older adults. As principal investigator of the Johns Hopkins Older Americans Independent Center, Dr. Wollstone exemplified translational research, bridging molecular discovery and patient care. He was a prolific scholar and generous mentor. He authored over 200 peer-reviewed publications and trained countless leaders in aging research. We were honored to welcome Dr. Wollstone as a distinguished speaker for the Global Frailty Network Frailty Seminar Series that you are all attending on at least 2 occasions. His clarity, depth, and visionary insight left a lasting impression on our global community of frailty and geriatrics. We extend our deepest condolences to his family, friends, and colleagues. And like I said, this is a special tribute to him as a friend and as a leader in the field of frailty. Thank you.
So welcome everybody to the Global Frailty Network Frailty Seminar Series. My name is Dr. Carmen Castillo Gallego. I'm a geriatrician and researcher in Spain. Our speaker for today is Dr. Aprahamian, who is going to talk about depression and frailty, a tale of 2 geriatric giants. But before introducing him, let me remind you a couple of things. As you know, we have 40 minutes of speech, and then we'll have some minutes for questions and answers. If you have any question, please write it in the chat button, which is on the bottom right of your screen. And now I'm going to introduce Dr. Aprahamian. He's a board-certified specialist in internal medicine, geriatrics, and psychiatry. He holds a master's degree in gerontology with a focus on dementia screening, a PhD in psychiatry focused on Alzheimer's disease, and a habilitation in geriatrics with emphasis on depression and frailty. Currently, he serves as Associate Professor of Geriatrics in the Department of Internal Medicine at Jundiaí Medical School in Sao Paulo, Brazil, where he also leads as Chief of Geriatrics and Director of the Medical Residency and Research Program in Geriatrics. He has twice been elected by his peers as Department Chief, overseeing a team of over 30 faculty members. Dr. Aprahamian is a prolific researcher and author of books and book chapters. In Brazil, he is widely recognized as a leading figure in geriatric neuropsychiatry and frailty research, co-authoring national consensus guidelines and editing key reference texts on Alzheimer's disease and psychogeriatrics. Internationally, he is the only Latin American physician to serve on the Frailty and Sarcopenia Research Group and the Global Leadership Initiative on Sarcopenia, contributing to multiple global consensus statements. He has held research affiliations with the Everett Hospital Psychogeriatric Unit at Harvard Medical School and is currently an honorary researcher with the Psychogeriatric Program at the University of Groningen in the Netherlands. So Dr. Aprahamian, whenever you feel ready, you can start.
Yeah, first of all, thank you very much, Carmen, for this very kind introduction. I'd like to thank you and Jorge for this kind invitation. It's a pleasure to be here. Of course, it's a very sad moment because of Jeremy, who passed away yesterday. I'd like to share my condolences with my friends at Johns Hopkins I was first introduced to Jeremy by our mutual friend, Chen Shu, and I have a lot of friends there, and special condolence for the family. It's a great loss. And now, today, I think we are the best form to honor Jeremy is to discuss about frailty, one of his passions. So the talk today will be depression and frailty, a tale of two geriatric giants. I will try to concept, especially the association between these two geriatric syndromes, as well as some insights regarding treatment for depressed, frail older adults. First of all, I would like to give a huge knowledge to my mentor and chief at the University of Groningen, Professor Richard Boschard. Richard is, I think, a leader in this kind of research. He was the first one that inspired me several years ago to pursue the investigation between these two geriatric giants. So a big shout out to Richard and all our friends at Groningen. So the aims for this 40-minute lecture, I will try to split in two topics. As I said, the first goal is to talk a little about depression, as we have a lot of good friends here and from multidisciplinary fields, and somehow depression is not so common at the day-to-day basis, and I think it's good to make some review in the diagnosis and some characteristics that is really important about depressive patients. And the second goal is to talk about treatment, and especially in frail depressive patients. So the first topic is talk about depression in older adults. As you might know, mood disorders are really common in our lifespan, and even after 60 years old, 65, mood disorders are still really prevalent. You can see that anxiety disorders become a lower incidence after 60 years, and mood disorders keeps like a stable, even a lower prevalence after 60 years. This is data from the Lifelines cohort study. It's a huge study from nowadays more than 150,000 community people from the northeast part of Netherlands, just the border of Germany. So this is a huge study with more than 5 years of follow-up, and we can see the importance, the epidemiological importance of depression. Regarding meta-analysis evidence about prevalence of depression, we can share depression between two big syndromes in geriatric field: the major depression, the more severe depression, and those patients that don't fulfill the full diagnostic spectrum of depression that we can call minor depression according to DSM-4. But nowadays we can call these patients like those with clinically relevant or important depressive symptoms. It's a very important topic since both conditions share negative health outcomes. So both are really important, and I will start highlighting this when we're going to share some evidence between frailty and depression. Depression diagnosis most clinically, we have some operationalization in DSM-5 since 2013. So we aim to identify the depressed mood and anhedonia, loss of interest or pleasure in daily activities. This is the main strain, the consistent one factor that we have, depressed mood or anhedonia, plus 7 other factors. The 7 other factors, I think the most important part is neurovegetative symptoms like fatigue or loss of energy, alterations of the sleep cycle, weight alterations or appetite loss, because neurovegetative symptoms are also seen in frailty and are very common in other geriatric symptoms or other morbidities that are really, really common among older adults. So this is highly specific if you think about depression diagnosis. Of course, when we think about depression, we have another kind of symptoms that are much more emotional or mood related, like feelings of guilt or worthlessness, suicidal thoughts or suicidal ideation. And of course, we have also cognitive complaints and cognitive signs, especially among older adults, like a psychomotor retardation or some dissective dysfunction. And of course, loss of memory, especially recent memory and attention. So depression diagnosis can be really, really challenging among older adults because sadness is less pronounced, like a blunted symptom, among olders. And so the true diagnosis suspicion sometimes is not so clear. And patients come to assistant with a higher somatic complaints, and sometimes this complaints really mess our rationale because we cannot identify depression, neither another geriatric syndrome or another common morbidity among seniors. And they have a higher cognitive burden and symptoms and signs that are more typical among older adults with depression. We talked about minor depression or those with clinically relevant symptoms of depression. We also could call this a subthreshold depression, a depression that not fulfilled completely the diagnostic procedure of DSM-5. And this is a really problematic concept because according to DSM-5, we have to have sadness plus at least one another symptom between the 8 syndrome factors symptoms that fulfill the diagnostic criteria of major depression. And sadness is blunted in older adults, so somehow it's tricky because most older adults with minor depression are not sad, and they have somehow anhedonia, and they are more isolated. They have cognitive complaints, fatigue, they have loss of appetite. So the diagnosis is not so easy. And the big issue is the negative outcomes that are really, really close to major depression. So we have the same problem. Major depression or minor depression is highly associated with negative outcomes that are really bothersome to older people. We have a lot of somatic outcomes of depression, as you know, from a mortality point of view, but we have a lot of cardiovascular and endocrinological burden associated with the onset of depression. And as I said before, we have a lot of negative outcomes associated with depression in older adults, like a loss of quality of life, functional decline, early admission of nursing home, premature death, and cognitive impairment, with higher odds to degenerative disease like dementia. So our second goal, or first goal, second part, we talk about association between frailty and depression, and I can say vice versa. Most initial research in this field try to investigate frailty as an outcome and depression as an independent factor. But of course, nowadays, after a lot of years researching this topic, a lot of studies try to look at frailty as a concept of accelerated aging, like a more biological status of accelerated aging. This is a really nice concept among mental health research. And of course, frailty as accelerated aging could higher the odds of depression and other mood disorders. So when we think about the frailty, we in the depression and frailty research field, we can think about first the phenotype. And because we think first of the phenotype, because we have shared factors between frailty and depression. As you can see, we have very common determinants like age itself, like female sex, like hormonal dysfunction. We have a lot of risk factors that are common to both conditions, but we have shared characteristics between the two syndromes. That's really, really hard to split both. So it's like we have some patient with a shared condition, like a frail, depressed patient. And this is really tough to make some research to try to separate the two syndromes, to understand the components and how they evolve. And of course, consequences are really, really common, like mortality, a higher burden of other morbidities, like negative outcomes from somatic disease. So it's really common consequence between frailty and depression. But we can also think about the concept of depth accumulation model. As you might know, this is a very nice model, not only for frailty on a multidimensional level, but it's a really good prognostic level. And in mental field research, we are using frailty index as a proxy for accelerated aging. And this is very interesting because we all know that both frailty and depression share several biological pathophysiological cascades. And as you are seeing, we have immunological alteration like a low level of chronic inflammatory signaling. We have many dysfunctional pathways from endocrinological pathways to mitochondrial dysfunction. And all these pathophysiological concerns are shared between the two syndromes. And somehow we can think about a geriatric depression as a concept that somehow is related to accelerated aging. And this accelerated aging may be reflected as the frailty component or the presence of frailty. As an example, here's some research of accelerated brain aging and relating greater disability in older adults with depression. As you can see the difference when we think about chronological and brain aging in adults younger than 50 years, for example, we don't have big difference. For example, the first here on our left, 32 years old, the estimated brain is 22, it's great. In the middle here, 33 years, the estimated brain here is 33. But when we look above here, just below, sorry, the geriatric patients here, the first one on the left, 67 years, and the estimated brain's 53, so it's a bigger difference. But when we see so many patients, older adults, for example, in our right corner, down in the right corner, 62 years, and the brain estimated level of 81. So this is much more typical than younger counterparts. So this accelerated brain or accelerated aging in mental disorders is really an important concept. So this is one of the key factors that move the research of depression and frailty association forward in the field. So first thing we have to see is big evidence regarding the association between depression and frailty. Of course, we have to start with systematic reviews and meta-analysis evidence. So we clearly have an association between both syndromes. If we look at the evidence of frail older adults, we have a high prevalence of depression, almost 40%, with odds ratio really elevated, almost twofold. And when we look at depressed older adults, we have also a higher prevalence, quite similar, 40%, and a higher incidence of frailty. One big criticism among this kind of evidence is that a lot of studies included in those systematic reviews were cross-sectional, or they had a longitudinal design, but with a short follow-up. So this is something that, of course, we have to see with criticism. But as an example, here's a cross-sectional study that we did some years ago. And the thing that we were really curious about, not only looking at the risk for frailty among depressive disorders, but also those older adults with depressive symptoms. As I told you before, those that don't fulfill the DSM-5 major depression diagnosis. As you can see, we use two different frailty conceptualizations here, the frailty index on my right and the frail instrument on my left. The frail is really nice if you think about a psychiatrist, for example, or someone other than a geriatrician, or someone from the primary care field. So we're not expecting that those people are very used to the frailty concept and to use a high level of diagnostic skills for identify frailty. So we tested both depressive disorders and depressive symptoms, and we tested both different complexity levels of frailty identification. As you can see, at a cross-sectional level, we have a higher level of association. When we move this kind of evidence to a cohort study, and this study we performed here in Brazil with a 1-year follow-up, we see the same phenomenon. Using the same instruments, both frail and a frailty index of 36 items, we observed a 2- to 4-fold increase in frailty incidence. So it's a confirmation of our cross-section identification. Well, we were not happy with this because we had only 1 year of follow-up. We tried to look at a bigger data with hundreds of thousands of people and with a longer follow-up. And then we decided to look at the lifelines population. And this population at the time of this study was more than 150,000 community people from the northeast part of the Netherlands. And we look at a 5-year follow-up. And we decided to try to investigate both directions of the association. So we split this cohort between two objectives. First, we identified those with mood disorders, both depression and anxiety, without frailty. And we look at incident frailty at 5-year of follow-up. And the second objective, we did the opposite. So we identified those without mood disorders, but with frailty, conceptualized by the frailty index. And we look at incident mood disorders, both depression and anxiety. And what we found, we look at, and this was a surprise, we had both associations very significant. So both the depressive disorders and anxiety disorders are highly correlated, associated with frailty in both younger and older people. And this is really important when we consider that we use the frailty index as a proxy of accelerated aging. And when we look at people before 60 years with this kind of association, and this is really important because we know that our brain starts aging, an aging process, and just before 6 years. And this can shed some light of public policies regarding the care of people with mental disorders before 60 years. And when we look at the opposite about the risk of frailty, when we identify depression and anxiety among these people, we had the same findings. When we look at both depressive and anxiety disorders split apart or combined in terms of psychopathology, we have the same burden. So, and I highlight again special interest among younger adults, which we don't think about frailty, we don't think about accelerated aging as a mental health perspective. So one can argue that we can have a lot of problems with the influence of many independent variables, factors, even in a large cohort with a long follow-up. And one form that we could design and to shed some light in the association between the two syndromes is from Mendelian randomization studies. So this is an elegant study using European ancestry, basically the UK Biobank. And when we use Mendelian randomization, we just do a genetically selection for recruitment, and we identify some polymorphism that can identify genetically predisposed conditions like depression and frailty. And then we can look at this kind of association in both directions. As you can see, both depression to frailty and frailty to depression, we have a very strong positive inverse variance weighted in both sides with some SNPs identified both depression and frailty. When we look at a multivariate association, taking care about BMI, age at menarche, and waist ratio that could interfere with the SNPs associated in this study, we still have the same strong association between the two geriatric conditions. In another interesting study, they did the same Mendelian randomization study. They used the UK Biobank and the Twin Gene Biobank. And what is interesting in this study, that they explore both concepts of frailty, both the frailty index and the frailty phenotype. And what we can observe is the same high level association between frailty and depression as an outcome. Moreover, they look at components, physical components like slow gait and low grip strength and low level of physical activity, and they had a significant association between those components and major depression. Obviously, that fatigue and loss of weight were not included because there's a natural overlap with the concept of major depression. When they did the opposite, they look at major depression and they think about frailty as an outcome of interest, they had another significant association, but at this time, major depression was not associated with the physical components of low strength, low gait, and physical activity at a low level. Moreover, we can explore physiopathological factors that could relate both depression and frailty, and they, of course, could explain this relationship. So this is another very nice publication using Mendelian randomization, and they explore a huge bank, the UK Biobank again, and doing Gene Biobank, but they look at mediation analysis, taking account several immunological factors as well as several interest brain regions to explore the relationship between both depression and frailty. And as you can look, there's an exposure response of frailty components and depression. As more you have frailty trait or component, you have a higher a chance to develop depression. It's a non-linear relationship, and we can see that age and male sex are highly correlated with this finding. Moreover, one interesting point is that mid-age were the mid-age people were much more significantly correlated in this kind of relation than older adults. And if we think about accelerated aging, accelerated brain aging, and mental disorders, we can think about this in the concept, a broader concept of frailty as a proxy for a bad aging regarding our mental health or brain health. And if we think about the population attributable fraction analysis, we can see that exhaustion or fatigue was the highest percentage of relation here, and the physical inactivity was the least one. The Mendelian randomization in this study was also highly positive in both sides, in both directions, and some inflammatory factors like CRP, neutrophil count, or leukocyte count were highly correlated. And there was an exposure response of CRP levels and frailty severity and the incidence of depression, as well as several brain areas that were highly correlated between the two conditions. This was quite interesting because some years ago we did this kind of question about how is the whole of frailty predicting mortality among older depressed patients. As you can see, this is data from the NISDO cohort. The NISDO cohort is a cohort of depressed older adults following up in an outpatient environment compared to other controls. And we can see that frail depressed patients have a higher rate of mortality when we compare with those without frailty, adjusted for multiple conditions. When we explore several biomarkers like inflammatory markers, vitamin D, and telomere length, we saw a nice relationship, maybe suggesting a pathophysiological whole here. And when we just look at the mortality rate here, but we adjust our regression analysis to this biological biomarkers or signaling, like a vitamin D, the telomere length, and the inflammatory biomarkers, we just lost the frailty as a mortality index or predictor for depressed older adults. And we explore this concept that frailty could contribute to mortality in mood disorders with, again, the Lifelines cohort, when we look at the mortality rates in mood disorders. And we didn't find something highly significant in our big cohort study. But the fact is that the frailty component, when we look at model 2 and model 3 is adjusted by frailty, and model 2 is just a multimorbidity adjustment. When we sum frailty for this model adjustment, we can see that although non-significant, we had a lower hazard ratio level that we can speculate that frailty is somehow contributing to mortality rates in older adults and younger people with both depression and anxiety. So what about treating frail depressed patients? Some words about considering treatment in these patients. We know from previous systematic reviews and meta-analysis that older people with depression has somehow a tendency of treatment-resistant depression. As you can see in this very nice systematic review published by Tedeschi a long time ago, when we split antidepressive effect from placebo effect, we can see that older people have a blunt response to antidepressant. And this is not the case when we consider just placebo. So there's a increasing negative effect of age when we consider the efficacy of antidepressants. And moreover, when we look at some evidence from the NESDO cohort, again, from the Netherlands, we see a correlation with the number of frailty phenotype components and non-remitted depression after 2 years of follow-up. And here we saw among the components of physical frailty, exhaustion, and low activity level were highly correlated. When we see about the response, if we consider depressive symptoms, we see that clear frailty, older adults with depression are less responsive to antidepressive therapy. But how about our evidence from systematic review and meta-analysis considering all published antidepressive treatment for late life depression? Well, we can just see that unfortunately we didn't include many patients with geriatric major conditions like frailty, disability, malnutrition, for example, and much of the amount of complex geriatric patients were just excluded from clinical trials of pharmacological treatment for late life depression. So what we know about treatment with antidepressant in older adults were just no evidence from fit or robust adults. And we don't know anything, almost anything about frail older depressed patients receiving antidepressant as a first-line treatment. So we start asking about the effect of antidepressants among older patients with frailty, and we did some cohort studies with 1 year of follow-up. Here's one example that we can see. There's an important factor here associating frailty with the use of SSRI in monotherapy. Patients here in this cohort study used the estalopram monotherapy or sertraline as monotherapy. And even though with one antidepressant and they had stable chronic depression, just addition of one antidepressant, they had higher odds of developing frailty. And when we adjust for several confounders, this effect of the antidepressant itself disappears, and the only thing that keep here is depression plus the use of antidepressant. So the question is, what's the whole of the use of antidepressant and developing frailty? We know that using antidepressant therapy higher our odds for adverse events, especially falls. And this was addressed by us several years ago in another cohort study. And for our surprise, just the use of SSRI as monotherapy elevated the risk for falls at 50%. And of course, if we had frailty in among these older patients with depression, we had 30% more falls, and frailty plus an antidepressant medication, we have more than 100% higher risk for falls. A clinical trial more recently tried to investigate the whole of antidepressant monotherapy using escitalopram 2 or duloxetine until 90 milligrams. And they look at frail patients versus non-frail. Non-frail we can call here pre-frail or robust patients. They put all in the same group. And they look at response and remission after 12 months. And you can see here both response in figure A and remission in figure B was lower among frail depressant patients. And the detail here that most is really important is that frail depressant patients receive twice the number of antidepressants than non-frail counterparts. So we're not treating this kind of patients very well. And in this study, they asked about the association of vascular burden and dysactive syndrome, and both factors didn't really matter about the association between lower response and remission with frailty status. And how we could concept the treatment for these patients. We have to think about psychotherapy as a first line because although many healthcare professionals doesn't believe in psychotherapy for older adults, we have compelling evidence that associates very nice clinical response with a large effect in treatment with psychotherapy for depression. And if you have someone with a higher level of intensity of depression, like a moderate to severe depression, we can, of course, prescribe a lower dose of antidepressant with adjunctive therapy with a psychologist. And how about diet? We know that we have to lower our inflammation in our diet. Is another example from a published study using a inflammatory index of the diet, and you can see that as more as depressive symptoms I have, if my diet has an inflammatory higher level, I have more chance of developing frailty. And there's an exposure relation, as you can see below in the graphic. This relation is in both frailty and depressive symptoms. And how about physical activity? Of course, if you have frailty, we have to consider physical activity. We have a large effect in physical therapy among older depressive patients, and we have to consider physical activity as a mainstream treatment, not only for frailty, as you might know from extensive literature, but also considering depression itself. So final words about this lecture here, and I have to emphasize about treatment. Always we have to consider identify frailty among depressed older adults. We have to consider, of course, antidepressant monotherapy, at least at lowest dose, and if possible, adjunctive psychotherapy, physical exercise intervention, diet and intervention among these patients, because they are more prone to adverse reaction and negative health outcomes. And of course, we have to try to implement individual target treatment components for frailty among older depressant patients. And what we can do about identify these patients, it's not so easy. If we think about psychiatrists, psychologists, and other healthcare professions dealing with depressed older adults, as you can see from data-driven approach, we have several phenotypes of depressed older adults. And we have pure depression, we have those frailty-associated depression, and those frailty-depressed older adults with cognitive dysfunction. So it's really tough. And of course, if you have frailty and cognitive dysfunction, we have a higher rate of non-remission. So it's really problematic because we it's not so easy to understand and to identify frailty, or at least frailty components, if you're not trained to do so. And this is a big problem if we consider health care professionals specialized in mental disorders. So this is a compelling evidence that we have to think about identifying frailty in the simplest way and the earliest time to highlight the best treatment for them. So key message for today, frailty is a reliable constricting depression. I think this is really clear nowadays, and there's a bi-direction between frailty and depression, vice versa. So we have to think about both conditions when we identify the first. Frailty is highly relevant to prognosis. If we think about prognosis itself in a clinical perspective, if you are considering treatment prognosis perspective, frailty will be a bad factor in terms of general prognosis. And finally, frailty maybe has a potential impact for depression management in a broader sense. And somehow, if we address frailty as a target for treatment, we could have a better prognosis in depressed older adults. But this is, we don't have evidence. This is just some thoughts for the future. Thank you very much again. And I'm glad to be here with you all. Thank you.
Thank you so much, Dr. Aprahamian. Let me just remind our audience that if they have any question, please write it in the chat. You have the chat button on the bottom right of your screen. So I have one question for you. So how can clinicians distinguish between apathy related to depression and reduced physical activity due to frailty in older adults?
Okay. Okay. Yeah. So this is an important concept. Resilience, in a broader sense, is a marker of better or worse aging, and I think lower resilience, it's really important for treating this condition. If we think about frailty as a broader concept, as I said, as a marker or a proxy of accelerated aging, this kind of factor would be very important at the earliest time. For example, younger depressed patients, and if we could identify those patients, of course, this will of course obligate us to change maybe our design of clinical trials against depressed people. So I think lower resilience, and it's a really important factor in this kind of relationship.
Okay, I think if you want to activate your camera and we can see you.
Oh, sorry. Yeah. It was just shut down, I think, for the.
That's all right.
Yeah.
Another question for you. What clinical markers or symptoms should alert us to screen for frailty in older patients presenting with late life depression? What clinical markers do we have?
Sorry, I didn't understand your
Yes.
question.
I will repeat. What clinical markers or symptoms should alert us to screen for frailty in older patients with late life depression?
Okay, yeah. So this is a tricky question because, of course, we have inflammatory markers, but they are highly non-specific. So this could be presented in several other conditions. I think the best marker is a physical marker. If we think about identifying the phenotype, or if you're working with a multidimensional a concept of frailty, like a frailty index, I think this is not the best way to identify those with risk or those with frailty. But one important observation is that we have a very recent publication from Groningen that we saw that slow gait is not so specific. For example, someone can just present complaining about, oh, my gait is slow, and this is not necessarily something that we're going to see in a objective way. And others will complain about slow gait, and this is mainly cognitive. And others will complain about slow gait, and they will have physically slow gait. You can measure this. And what's not clear is that this kind of phenotype appears to be really important, because 30% of patients have one of each component. For example, some only subjective, only physical, only cognitive. And there's a really small correlation between these factors. But I think the only way that we can identify this kind of patients is measuring. So it's really tough to imagine a psychiatrist just measuring gait speed. So we have to conceptualize that the best way to treat these patients is multidisciplinary teams, which is really expensive.
Mm-hmm. So what you're telling us is that at the same time you start an antidepressant at a low dose, you should start exercise, physical exercise, psychotherapy, and not focus so much on medication.
Yeah. We believe that we have to spare the most antidepressive burden, but it's not practical, because we deal with a lot of severe depressive patients. So it's not realistic that we can just advocate for not using antidepressant. This is not realistic. So we have to prescribe antidepressive therapy, especially for those more severe. But we have to keep in mind that this is not the only way of treating these patients. That we have to deal with their diet, their physical exercise, the psychotherapy. So if we deal with other components involved, we can change the prognosis of this patient, and maybe we can have a better response and remission in this patient. This is what we can depict from the publications nowadays.
Thank you. I have a question. Excellent presentation. Thank you. There were a number of studies that explored different depressive conditions and clinical markers, frailty syndromes, and included them in studies to understand correlations between frailty and depression. Can you tell us that what types of data were used, such as ICD-10 codes, SHOWMED, responses from patient questionnaires, or data collected from OGAs, etc.? CGA, sorry, etc.
Yeah. So we have to keep on mind that especially the initial literature in the field, they used initially codes to identify depression. This is not ideal, because not necessarily that people were really depressed, and first of all. But the second part is that when we think about someone, an older adult with depression, if this kind of person is identified as depressed by a screening scale like the CSD or the GDS or the PhD. It's really simple, and maybe this is not the best way to diagnose this person, because of course if you have a heart failure, for example, and someone comes and say, well, let me screen your depression, let's do a GDS or PhD, and of course you have some numbers that will point to depression, because you have fatigue, you're not sleeping well, you're not eating well, and your thoughts are not good, and not necessarily you're depressed. And what we saw that several previous papers look at this kind of a relationship in this way. So this is a misconception, and but nowadays we have a lot of very nice papers that look at the formal psychiatric diagnosis, and even genetic establishing depression and frailty as really structured factors. So I think this is not the case anymore.
What integrated care models do you know are effective in managing patients with depression and frailty in long-term care settings? Do you know any models?
We don't have the literature from long-term care nursing home is really weak. So we don't have I can say we don't have it, because we don't have anything with a high level of quality. So, and we have to assume that those patients are the more severe, both in terms of depression. We can think about those with the more severe form of depression, like psychotic depression, and of course those patients, I can imagine, they will be really frail. So we don't have literature for this patient.
And do you have any kind of experience with artificial intelligence? I'm working right now in a nursing home, and we are using virtual glasses for our patients with anxiety, and they actually like it a lot. Do you have any experience with artificial intelligence?
No, we don't have it. You know, Carmen, we have a lot of artificial intelligence that nowadays just recognize like a facial recognition of mood disorder, like bipolar disorder, for example. And of course, technology would facilitate, I think, the treatment and identification of those patients. But nowadays, we don't have literature with this kind of approach. And I think both conditions, both frailty and depression, would be better evaluated with technology, because you can just scan a gait from a patient and identify if he's frail or not. And the same is true for depression, for some behaviors that we can just observe, for example, in a non-special environment. And this kind of observation, maybe with artificial intelligence system, can identify, for example, a depressed older adult.
Okay. I have here somebody who says, Friends Original, I don't know. FP paper excluded patients with depression. If you exclude depression, can you still meet FP criteria for frailty?
Oh, yeah. Yes, Julian was right. The original frailty phenotype concept by Linda Fried excluded depressed older adults. I talked to her several years ago, and well, she was really smart. She observed that depressed older adults had a higher prevalence of frailty, and they were weaker, slower, and she thought that including those patients would, make a mess in the analysis, especially the prognostic analysis. that she designed. So this is an issue that we have to be really careful, because when we think about the phenotype, we have an overlap, a natural overlap between components. As I told you before, we have depression and frailty sharing neurovegetative symptoms like fatigue, sleep cycle alterations, appetite loss, weight loss, and it's difficult to split like, oh, this is frailty, oh, this is depression. We cannot do this in a real world analysis. So this is not easy. I think in a clinical perspective, this is not easy. And for several years, we were, of course, suffering from this difficulty to design proper studies, from cohort studies especially. And nowadays, I think we're still struggling with clinical trials, because it's tough to include frail patients, first of all. And it's not easy to identify a better response of a frailty components during the clinical trial, because maybe when the depression is better, those people will do more exercise, they will eat well, and it's difficult to identify that well, my psychotherapy or my antidepressant just reverted frailty. So it's impossible to compensate this kind of influence.
Yeah. Well, thank you so much. We don't have time for more questions. Just remind our audience that next July 7th, we have another seminar, which is the last one for this year, Moving the Needle on Frailty Through the Lens of Aging Heterogeneity, which will be presented by Dr. George A. Kuchel from University of Connecticut in USA. So thank you so much, Dr. Aprahamian. It was wonderful, and see you around. See you everybody in 1 month.